next expert is Professor Stuart Phillips. He's absolutely well known for his work on protein interventions in this at-risk population in people with sarcopenia and frailty. He's a full professor in the Department of Kinesiology and a member of the School of Medicine at the McMaster University in Canada. He's a Tier 1 Canada Research Chair in Skeletal Muscle Health, and he is the director of the McMaster University Physical Activity Center of Excellence. So he's really a world-class researcher, and he will cover the theme of a perfect match, protein supplementation, and exercise in mitigating the consequences of muscle loss.
Hi, my name's Stuart Phillips. I'm a professor in the Department of Kinesiology at McMaster University. I'd like to thank the European Geriatric Medicine Society and the Nestle Nutrition Institute for allowing me to give this talk today. The title of my talk is The Perfect Match: Protein Supplementation and Exercise in Mitigating Muscle Loss, Action Against the Disuse Crisis. These are my funding and disclosures and means of contacting me after the presentation if you would like to do so. I'd like to talk to you today about sarcopenia, which, as we all know, is the age-related decline in muscle mass and strength and function as we get older. The traditional estimates are that we lose muscle mass at a rate of about 1% per year, and muscle strength up to a rate of about 3% per year. The causes of sarcopenia, however, are multifactorial. We know that there could be a hormonal component, there could be something to do with microvascular circulation, or we could have limitations within the muscle itself. But two factors over which we do have control are exercise and nutrition. The problem is that older people have something that we have branded anabolic resistance. Anabolic resistance in this sense is a resistance of the muscle to the normal anabolic stimuli of exercise and protein. So let's talk first about protein. Most of the discussion is going to focus around protein requirements and then the types of protein that older people should be eating. We're going to borrow heavily from this paper that Dan Traylor, a postdoc in my lab at the time, and I wrote to show you that protein requirements for older people are actually greater than current recommended intakes. When we look at the studies that form the basis of protein requirements, and specifically highlighting the meta-analysis by Rand and the paper by Campbell, you can see that these studies were based on the techniques of nitrogen balance. When we look at the protein requirements specifically, you can see that both the Rand meta-analysis, even though they had very few subjects that were older, and the Campbell paper found that the protein requirements of older individuals were not much different from the RDA of about 0.8 grams per kilo per day. However, a reanalysis of the Rand data by Humian et al. Showed that when you included higher protein intakes, older individuals probably had a requirement closer to about 1.05 grams per kilogram per day. At the same time, if we include studies that come from using the indicator amino acid oxidation method that show a substantially higher protein requirement, we would conclude that the average requirement for older people is closer to about 1.16 grams of protein per kilogram of body mass per day. And in fact, that estimate is reflected in current expert intakes, which are listed on this slide. In other words, the minimum protein intake for healthy older people would be in the range of about 1 to 1.2 grams of protein per kilo per day. And you can see a staircase of increasing requirements going up with acute or chronic disease, or severe illness or injury, or marked malnutrition. So what are older people consuming in terms of protein? I think it's important to realize that if we use the RDA as the bar to which we're comparing usual intakes, we will always say that older people are not doing too badly. And that's exactly what's shown in this slide, which comes from our review paper. If we look at the percentage of actual protein intakes in men and women over the age of 70 years, you can see that a substantial portion of them are consuming above the current estimated average requirement for protein and above the current RDA. So maybe it's not an issue. The problem is is that that does not reflect the more up-to-date knowledge that we have that protein requirements are greater in older people. If we look at the proposed estimated average requirement and the proposed RDA of 1.2, you can see that only a very small percentage of older men and women are consuming sufficient protein, probably in the range of about 5 to 10%. So what about older people then and the protein landscape? What do we know? We know, for example, that aging is associated with a reduction in food intake, which is a predisposition to energy and protein undernutrition. We also know that older people that consume protein at the RDA level have a reduction in muscle mass, muscle cross-sectional area, and even strength. And this can be seen in a short period of time. So in short, older adults need more protein than the RDA. I would suggest that 1.2 grams per kilogram per day is the minimal intake that should be offered to older adults to slow and mitigate muscle loss as much as possible. And what's clear is that older adults are not consuming these intakes. So we need to begin to counsel individuals, particularly as they age, to optimize their protein intake. The tissue substrate that we're most concerned about, obviously, with aging is skeletal muscle. And I'll just give you a short introduction to how we view changes in skeletal muscle protein balance and how they fluctuate throughout the day, the impact of aging on those changes, and the impact of physical exercise. This figure shows you the changes in muscle protein synthesis in yellow, muscle protein breakdown in red, and then net areas of accretion or muscle gain in green, and muscle loss in gray. You can see that with each eating occasion, the subsequent hyperaminoacidemia that comes from ingesting protein results in a marked stimulation of protein synthesis. However, that stimulation is transient, and within hours, there's a sharp reduction in protein synthesis, and now instead of having a net accretion of muscle, you have a net loss of muscle. You then subsequently eat a lunchtime meal, you get a further restimulation, and subsequently a dinner time meal. If we look at then what happens with aging, this is the phenomenon that I spoke about, known as anabolic resistance. So individuals that are older have a smaller anabolic response to a given amount of protein than do their younger counterparts. Quite simply, what we could do to offset this is to feed older people more protein or higher quality protein, as I'll discuss, or we could have them be physically active. With exercise, and particularly loading exercise, both the amplitude of protein synthesis is greater in the fed state, and the declines are less in the fasted state. The sum then is a more anabolic muscle that is going to retain more amino acids, probably from the breakdown process itself, but also from the dietary component. Well, what about protein dose? We set out to answer this question, and we wanted to ascertain, after resistance exercise, what would happen to protein requirements in younger and older individuals. You can see from these two graphs, and these are generated from a paper by Dan Moore, a PhD student in my lab, and Dan has shown you here that the myofibrillar protein synthetic rate, which are the force-generating proteins in muscle, rises and then reaches a plateau, the break point of which is 0.24 grams of protein per kilo per meal. In older individuals shown at right here, you can see, however, that the relationship is shifted to the right. Older people are still able to achieve rates of muscle protein synthesis that are similar to younger people. The problem is they need to ingest more protein, and probably better quality protein, than they're ingesting on a habitual basis. In fact, the per meal estimate from our analysis here shows you that older people should be consuming 70% more protein on a per meal basis than younger individuals. Another problem, and what I really haven't addressed in the schematics, is that most people consume their protein intake in a skewed fashion. So to show you what that looks like in reality, this is a figure drawn by Saroikawa, and you can see in a review paper that we wrote, showing that people probably consume the smallest amount of protein at their breakfast meal, about 12 grams, a moderate amount at a lunchtime meal, but the greatest amount at the dinner time meal. You can see that there's a pre-bed snack consumed by this individual of only about 10 grams, and then there's a subsequent period of overnight muscle loss, if you like, because the person isn't eating. But if we use those per meal thresholds, you can see that a younger individual reaches that plateau on 2 occasions, at both lunch and dinner time. In fact, at dinner time, they surpass that intake. An older individual, however, who requires about 70% more protein per meal only hits that threshold one time in the day. And it really does bring up the question of what's the importance of the protein source, or what's the quantity of protein that we should be consuming not only throughout the day, but at each meal. So the active amino acid in this process is clearly the branched chain amino acid leucine. It's one of a family of 3 amino acids, including isoleucine and valine. However, it's leucine that is specifically responsible for turning on the process of protein synthesis by signaling through a pathway that culminates on mTOR stimulation. We know from the work of David Sabatini's lab at MIT that leucine binds to a protein called cestrin-2 to initiate the protein synthesis process. That's led us, and several other researchers have reached the same conclusion, to propose something that we call the leucine trigger hypothesis. The story here is that leucine needs to reach a specific intracellular concentration to trigger a full and robust protein synthetic response. This figure here shows you a low and a high dose of leucine. You can think of these as low and high doses of protein, and to show you that the protein synthetic response is graded in fashion. However, once you've reached the trigger threshold, you don't need to consume more protein, or specifically more leucine, because you've got the full anabolic response. Importantly, exercise can lower that trigger threshold. In other words, exercise sensitizes the muscle to the presence of leucine and triggers a full anabolic response. Obviously, to have this keep going, we need to exercise periodically. At the same time, if we're older, or we're made to be immobile, or we have a metabolic disease like type 2 diabetes, for example, then the protein or leucine threshold is higher. And this is an important finding because recently, Dr. Glenda Courtney Martin showed that the leucine requirements for older men and older women were almost twice the current estimated requirement. And they suggested that leucine could be a limiting amino acid in the diet of older adults consuming the current RDA, or in older adults consuming plant-based diets simply because of the lower quality of protein. What then might be an optimal protein combination? And there's no doubt that the highest quality proteins that are consumed on a regular basis come from dairy. That's because they contain 2 protein fractions. Whey protein, which is high in leucine, is acid soluble and rapidly digested, and so it triggers a robust rise in muscle protein synthesis. Casein protein, on the other hand, is a slowly digested protein, and its amino acids appear gradually after ingestion, and the effect that this has, at least at the whole body level, is to suppress protein breakdown or proteolysis. At the whole body level, then, when whey and casein are consumed, we know that you get a superior net whole body protein balance. And in fact, in our hands, combinations of whey and casein optimize the amino acidemic profile, both for leucine appearance and for all of the other essential amino acids which you need for full muscle protein synthetic responses. Well, what about the other pillar that we can tell older people they should optimize? This is clearly the performance of physical activity. Exercise being a subcategory of physical activity in which there is intent to either become stronger or to become fitter. When we talk about cardiorespiratory fitness, we're talking about the integrated functioning of the heart, the lungs, and the musculoskeletal system. And interestingly enough, a specific American Heart Association scientific statement says that cardiorespiratory fitness could be a fifth vital sign, mostly because it is highly predictive and prognostic of mortality than established risk factors such as smoking, hypertension, and high cholesterol. So cardiorespiratory fitness would, if you're making a prescription for an older people, be something that should be maintained and, if we can, enhanced for as long as possible. We now have evidence-based support for aerobic exercise, which is the primary activity that drives cardiorespiratory fitness, lowering the risk or improving the prognosis of heart disease, certain types of cancers, type 2 diabetes, dementia, and I think within the next few years, you're going to see compelling evidence of an association between the performance of aerobic exercise, cardiorespiratory fitness, and the mitigation of risk of depression. What about strengthening exercise? When we talk about strengthening exercises or balance exercises as well, these are the types of exercise that are emphasized in the most current guidelines for older individuals. When we look at the evidence basis for strength, we can say that the performance of strengthening exercises lowers the risk of mortality and/or morbidity for cardiovascular disease, again, certain types of cancer, for morbidity associated with osteoporosis, and mobility issues associated with osteoarthritis, as well as type 2 diabetes. What then would be the optimal combination of performance of these types of exercises? I'm going to lean heavily on the most recent international exercise recommendations in older adults, and these are the expert consensus guidelines. I normally don't like to show tables as proof of concept here, but in this case, I think this table summarizes very nicely when we talk about some of the age-related frailty and sarcopenia syndromes, as well as fall and mobility impairments and cognitive impairments. Quite simply, the recommended exercises range from performance of resistive training, so to keep a person strong, power training, so to move a weight rapidly, as well as balance and gait exercises, including dance and Tai Chi. When it comes, however, to cognitive impairment, it appears that aerobic exercise is superior. We need to walk on a regular basis or practice large muscle group aerobic type activities. What about inactivity and disuse? These are the scenarios that I think are watershed moments for older individuals. Quite simply, when an older person becomes inactive or has a period of disuse due for whatever reason, could be that they are resting at home, as we've been instructed to do throughout this pandemic, or it could be a hospitalization. These are watershed moments for older individuals. We know that people are already on a sarcopenic decline in terms of their muscle mass and their muscle function. But what happens when somebody is made to be immobile is that they experience an accelerated loss of muscle mass. So you can see the schematic of a cross-sectional area of somebody's thigh here experiencing the normal age-related decline in anabolic resistance compared to an individual who has had a disuse period and is now shifted down to another family of decline and would probably hit some sort of functional threshold earlier in life than the individual who didn't have the disuse period. Quite simply, this begins to set up what Sarah Oikawa has written about in this review while she was in my lab, that there is a cycle of inactivity-related sarcopenia. An inactivity event, be it caused by joint surgery, hospitalization for illness, or simply recovery and recuperation from something like the flu or from COVID. Simply, these people engage in bed rest, they're made to be inactive, they have a reduction in their energy intake as well as their protein intake. This leads to an increasing anabolic resistance, so they have a reduced magnitude of muscle protein synthesis and they lose muscle mass. These are events that older people find it very difficult to recover from. Quite simply, we need to intervene aggressively in these situations to mitigate muscle loss. We need to introduce physical therapy early when a person is hospitalized or even when they're made to be immobile and often. And we need to consume protein in close temporal proximity to the performance of physiotherapy. It would be a good idea to promote the use of high quality proteins, particularly with high leucine. And there could be other ingredients such as creatine or omega-3 fatty acids that could enhance the effects of dietary protein. But the whole goal is to mitigate the decline and to help these patients recover as quickly as possible. So what are the take-home points? First of all, protein requirements in older people are elevated, and many older persons are not consuming these types of intakes. Higher protein intakes are associated both with greater lean body mass and improved function. The difficulty has been in showing in interventional studies that you can preserve lean body mass and you can preserve function. The major problem is that the size of the studies that would need to be performed and the length of time that you would need to have this intervention are simply beyond the scope of what's currently been done. Leucine appears to be a key amino acid, which emphasizes the role of protein quality, and especially dairy proteins, which have the two fractions that we discussed, whey and casein, that are naturally high in leucine. It would be a good idea for older people to engage in physical activity and exercise of many or any type to improve metabolic health and preserve their muscle. And inactivity, even when periodic, represents a time when older people lose muscle at an accelerated rate. And it could, in some individuals, represent a permanent loss. This is a major step towards disability. So there needs to be aggressive nutritional support and physical exercise during this catabolic inactivity crisis to mitigate losses of muscle mass and to support recovery. I want to thank you all for taking the time to listen to my presentation, and I look forward to hearing your feedback.